The first speaker this morning to talk about rehabilitation and transfemoral amputation would be Harmen van Linde from Holland, the Netherlands, and you probably all know him from yesterday, so I'll leave it here.
Okay.
Thank you.
Thank you, Mr. Chairman. Good morning, ladies and gentlemen. Welcome to this session on the transfemoral amputation level. Yesterday we started already, I think, with this level, and now we have the subject of the rehabilitation of the transfemoral amputation. Later on we come to the prosthetic aspects, so I won't say much about that. And this is more a general overview of what you can come across in clinical practice. So I will shortly say something about the pre-operative phase, the post-operative phase, and the prosthetic training. So in the pre-operative phase in the Netherlands, the rehabilitation doctor is asked by the surgeon to give his or her advice about the amputation level and about other aspects which we should take in mind before the operation is done. And in advising the amputation level, what do we look at? We look at what is the clinical situation, of course. We look at the functional abilities and what we are, and if we are able to predict the functional status afterwards is, of course, important, but it's not always easy. We look at the arterial status, but we have to say that the decisions are mainly based on our clinical experience. So the end result is that we make a decision about the amputation level. And we also have to say, well, if it's a surgeon with enough experience, then it's no problem. I won't say something about how to do the operation, of course. But in the Netherlands, the situation is still so that we have to say this has to be the stump length, make a myodesis, and attach the adductors. So those are strong advices, but it was already told about in the presentation about the surgery, of course. This will come later. Sometimes we have some discussion about the stump length and the situation around the hip. And if you come across these kind of problems and you have a very short stump length, should the hip disarticulation be an alternative? It's still a question, and maybe we can discuss this later on, because sometimes it has been done as a better alternative because the prosthetic fitting is rather problematic. But I want to give an answer now on this one, so remember it. In the post-operative phase, the stump treatment, we have two kinds of treatment possibilities, the soft dressings and the rigid dressings, and as you know, as told before in the post-operative management in general, the rigid dressings is the better option. But still, in a lot of places, and especially in the Netherlands, soft dressings, elastic bandages are used still, and in our rehabilitation team, it's still favored at the transfemoral level. So here you see an example of how you start the bandaging. It's learned to the patients by the physical therapist or the rehabilitation nurse. You have to do that at least 5 times a day, The bandage goes around the pelvis, and of course when you have to do this 5 times a day, it's not always possible to go to the physical therapist. If it's an in-hospital situation, it's more easy, of course, to have it done by a nurse or a physical therapist, but most of our patients are going home. They are outpatients, and they have to do it themselves, so learn the patient how to do this. Or someone at home, a partner or someone else. Then the physical therapy starts. In the transfemoral level, we have to be careful with the hip mobility. Flexion contractures are, if you're sitting in a wheelchair often, and then it's a risk. So the balance training is another thing, and the trunk balance, trunk position is also very important. These are aspects I told you earlier in the general physical therapy presentation, but I mentioned them here also. So the measurement of the residual limbs range of motion is of importance. Treatment of contractures, hip and knee mobility, not knee mobility in this one, of course. Functional strength of major muscle groups, bed mobility, sitting and standing balance, and the transfer skills. Activity as soon as possible after surgery. There's some negative aspects, of course, of immobility. Re-establish the personal independence and the psychological advantage derived from activity and independence is very important, and that is a motivation throughout the process. We're dealing with comorbidity, as told earlier, so cardiac training and endurance training is of importance, and we can start with progressive general exercise programs to have better conditions, and we give advice about lifestyle. So we train transfers, wheelchair propulsion, unsupported standing balance, ambulation with assistive devices, balance and coordination training. And if we come to a prosthetic prescription, we start, of course, the gait training skills, and if possible, then depending on the predicted level of activity, advanced gait training activities. And we do that within different training modules. An X-ray can be useful post-operative, as you see here. There's a fracture of the femur, and should this be treated or not? In this case, it was left this way, so a conservative treatment, and later on, it gave some problems with the prosthetic fitting, and in a later stadium it was operated and removed, because at first it was thought that it wouldn't give so much trouble, but the fitting can give some problems here. But it's merely about the advice to make an X-ray if there are a lot of problems, pain at the stump. For the prosthetic prescription, look at stump fitting, the knee mechanism and ankle foot mechanism. I won't say much about the prosthetic aspects, because this will be in a later presentation. But the prosthetic prescription is mainly based on the level of activity and specific aspects on the participation level. So the home situation or employment situation that ask for adaptations to the prosthetic prescription. Looking at stump aspects, regarding the socket, we have this is let's say a normal situation, a conic shape of the stump, a normal muscle status, and there are no specific skin aspects, so no scars or whatever. We have a normal stump length, a normal stump shape, and for the socket we have some basic principles, the narrow medial lateral fitting or the quadrilateral fitting, but in the last decade I think we come across more hybrid socket principles where we use the several principles. And in the Netherlands, you see mostly for the younger people the narrow medial lateral fitting, and for the older people more quadrilateral fittings, as you see here. And sometimes we still use a rigid pelvic band. It can be said that it's a bit old-fashioned, of course, but we still use it if necessary, and you will see it later on a slide also. So then we come up with a prosthesis like this, and we first start in the training with stability, and we move on from stability to a more dynamic skills and the dynamic alignment. Here you see the prosthesis on the patient. But we can see, of course, different stumps, and here you see a lot of scars on the stump, and this can give some trouble with the prosthesis you saw earlier. So here we use a liner with a cord fixation in this case. Here you see it on the patient. But you can see also a lot of other problems, and this is no standard situation. Here we don't talk about a normal stump. This is a lot of atrophy throughout the years. So here you have to come up with something else. We choose a gel liner, and the suspension was partly by a hip bandage with a rigid pelvic band, as you see here. So maybe a bit old-fashioned, but it works very good in this patient. Here you see a very short stump and also a very difficult skin situation, combined problems, where we also put it back again. It doesn't work. Okay. But here we started also with a gel liner, and what we can say in conclusion about the socket is that gel liners or other liners are used as a standard, also in the transfemoral level, and as an alternative you can always go back to the rigid pelvic band. About the knee mechanism, I won't go into this because it will come up later, I think. But there are some principles you have to look at: stability control and adaptation to, for example, walking speed. So prosthetic prescription is based on the skills and the activity, and we use mobility classification in this prescription process. At the participation level, we have to look at the daily activities in specific home situations or employment situations. And of course, there are the wishes of the patient, sometimes dealing also with cosmetic aspects. Okay, some general aspects. These were about the rehabilitation at transfemoral level. So we can go on with the next subject. Thank you.
Thank you very much for your presentation, Harmen.